What I'm going to be talking about today is I'm a clinical researcher and a child and adolescent psychiatrist by training, and I would like to talk with you about the continuity of care and kind of update you about some of the clinical research we are conducting with adolescents. By the way, we have a nosological difference. I have an issue with the term young people, and I'll tell you why. Because adolescents are not miniature adults. And lay people, when they hear the term young people, this is what they think. I would like to address them as children, adolescents, and emerging adults, and also show you what are the differences in terms of development. Another comment is, let's kind of check your rock and roll IQ. How many of you know who is Jeff Beck? Raise your hands. Good. Jeff Beck is the best still living guitar hero. Jeff Beck has an album that came out last year called Loud Hailer. Amazing, and the concert was fantastic. And he has a song, check it on YouTube, it's called Right Now. And I like to cite to my patients my rock and roll stuff, so it goes like this. I won't play it to you right now because you get too excited. And then it'll take me time to calm you down. But it goes like this. They want it right now, even though they don't know what they want it right now. When I hear something like this, it equals adolescence. So towards the end of my presentation, we'll talk a little bit whether we should give the people what they need or what they want, especially with adolescents. How do we combine the two together? Because adolescents think they know everything, but that's why we have so many casualties. And because of this mismatch between emotional maturity and intellectual maturity. And we need to understand it because it's kind of complex working with adolescents and especially engaging them. Okay, so let's get to the real thing. That was my intro. This is a disclaimer that I'm conducting research that is funded, and I also publish several books, so you know. Well, if you want to know where I'm from, it's this little thing that is most probably the size of Sydney metro area. It's called Connecticut. It's the red dot in the ocean, kind of. So we are located between New York State and Massachusetts, between New York City and Boston. And all this area above us is called New England. And I'm also showing you this slide because we were one of four national sites, and we have conducted so far the largest ever treatment study of cannabis use disordered in adolescents, N equals 600. And there's a lot of data that came out of it and several manuals for treatment. Those of you who use motivational interviewing, CBT, MDFT, which stands for multidimensional family therapy, ACRA, which stands for adolescent community reinforcement approach. All these manuals were developed during the study that was funded by the Center for Substance Abuse Treatment. So we have a lot of experience. I think that my little shop at the University of Connecticut, we have treated about 1,500 adolescents with cannabis use disorders. So we definitely have some experience. And recently I wrote an editorial, The Blind Side of Addiction, a call for developmentally informed research. That's kind of my comment about adolescents, that unfortunately a lot of our colleagues work with adults and don't recognize developmental perspectives and how important they are. And some of the older addicts that they see, started much earlier, and the question is, what have we done with them earlier? So it's very important to be developmentally informed when we work with young people. Now, this is a typical ad of ours. Do you know a teenager struggling with marijuana use? That's a study we completed last year when we worked mainly with poor responders. And I'll get into this issue very soon because I'm not interested in our success. I'm interested in the patients or the adolescents or the people that we don't do very well with, how to recognize what is their problem and how to make them do better, which is a very important issue. As you know, in medicine, about 20% of the patients consume 80% of the resources because they are those that are difficult to treat, they have poor response to treatment, and that's why we need to invest in them more. Now, a little bit of solicitation. Last year, we started a new international society. It's called the Research Society on Marijuana. You can look at the bottom how to get into our website. We're also going to have a new peer-reviewed journal. And funny, I mean, the first meeting and the next meeting are in Colorado, which you know is the #1. It's kind of Disneyland for cannabis users with a lot of problems associated with it. And so just kind of give you an idea what we're doing. We welcome researchers or anybody who would like to come to this meeting. It's really a very exciting experience to evolve with a new research society. Now, this is what I will try to cover, and I'm hoping that I would be able to. I'll try to talk fast. But I think it covers pretty much everything I have in mind. Because we talk about continuity, I want to talk with you about the power of assessment, because assessment is therapeutic. I want to talk a little bit about the elusive patient treatment matching concepts, which is the holy grail in medicine. Because we are the next generation, yours or even further, we will talk about personalized medicine. Personalized medicine does not mean just, one-on-one issues, is that we will be able to use information, genomic information, environmental information, and tailor specific treatment for people. Why is it important? Because the patient population, whether it's diabetes, schizophrenia, epilepsy, and substance abuse, is highly heterogeneous. If we want to make progress, we need to break it down into several more homogeneous subpopulations and work in each one of them. This is really the way to success, and the question is, how do we make this matching? Because it's very elusive. How do we get there? And one of the issues is big data, big brother, that scares us a little bit now in terms of technology, who have this information, what they can do about it, but there's definitely a lot of important information that can help us advance medicine. Mechanism behavior change, this is the vogue in the last 10 years. We are trying to understand predictors, mediators, and moderators. Because especially in the addiction field, we base our work on experience, on traditions. They are nice, but it's not enough. We need science to get in. We need facts, not just ideology, and we need to make them work together. So this is what we call the evidence-based practice. And as like my colleague John Kelly said, what about evidence-based practice, EBP? What about PBE? What about practice-based evidence? Meaning, how do we take into consideration and integrate the experience that we have with the new technologies and the new information that we have? And we need to move forward with whatever better for our patients. Sometimes we struggle because we know certain things, or we know how to treat in a certain way, and we swear by it. But there's a problem, because I don't care if you do family therapy, individual or group, the bottom line, we need to understand the mechanisms that make behavior change. Because my analogy is, if you're an expert using fork, you're pretty good in, eating your salad, but you won't be able to eat soup. And vice versa, if you're great with a spoon, here goes your salad. So the bottom line is we need to be flexible. We need to understand what is in the best interest of our patient. And that's why we need to get out of these silos. I'm just a family therapist. I'm a prevention specialist. It is not helpful. We need to have continuity of care because the mechanisms that we use are very similar. The presentation is different. We talk about adaptive treatment. In a nutshell, we used to talk about, if you are into AA, 90 meetings in 90 days, or 12 weeks customary treatment. We don't have time for this. Life is short. We need to understand when do we make the impact. And I will show you that, for example, in treatment, between 4 to 6 weeks, you can measure and know whether your patient is making serious progress or not. If he or she does, hallelujah, keep on doing what you're doing fine. If they don't do well, you need to switch to something else. You don't need to complete the 12 weeks. Why? Because this is like all these economical curves of diminished return. The slope in the beginning is very steep and it's great. then it plateaus, and you need more and more energy, more and more resources to make a very minor change. We don't have time for this. So for example, in CBT, within 5 to 6 weeks max, 90% of the patients who would respond have already responded. Great. What about the other 10%? They need to move to something else. That's what we call adaptive treatment. Like with medications, somebody has depression, you give an antidepressant, it doesn't work after a certain time, that is in the algorithm or decision tree protocol, then you have some other branches, and or. You may change the dosage, the frequency. You made another medication. You made another component, like psychosocial component. You may add all kind of other things, all kind of devices that are being used right now with the treatment of depression. You don't just wait for things to change if you know that the process is maxed its options. So that's something very important to understand, and I'd like you to think that way, if I may, when you work with your patient. Things don't work very well. What are we going to do? What are we going to change? Don't just continue the traditional treatment. And I also understand there is the reimbursement issue, which can be an issue, but nevertheless, if you want to move in the right pace for the best interest of your patient, things don't get better, you need to make changes. I'm going to talk with you briefly. We developed a very interesting assessment for goal commitment, and if we have time to talk about abstinence versus harm reduction regarding adolescents, which is an interesting issue, and how do we define harm reduction, and where do we go from here, and hopefully we will exchange some comments and questions. Somebody can give me like 5 minutes warning before I'm done, because otherwise I'm going to talk all day. Okay. So I know that you had the pleasure, some of you, to listen to Patricia Conrad, who is, a major contributor to prevention. This is my only slide about prevention. And I think that one of the issues, similarly to what her group is doing in terms of prevention, addressing early risk behavior in targeted interventions, particularly sensation seeking, is extremely important also in treatment, because our patients are different from each other. For example, talking about young people versus adolescents or emerging adults, in any kind of medical problem, including substance abuse, it's not an exception, there are 3, 4, even 5 different trajectories. At least two of the trajectories usually are quite morbid or toxic. That's why when we work with adolescents who don't respond well to treatment, these are those kids that the severity of the problem still keep on rising. That's why we have this helplessness feeling as a therapist. If none of you have had it, I envy you. Things don't get better. And sometimes they don't get better because this kid trajectory is still going up. And it's like swimming against the current with those kids. So we need to understand what's happening with them, particularly until age 25, when the brain matures and it plateaus. But we don't have time to wait, like AA, until they hit rock bottom, because rock bottom can mean morbidity and mortality. So, but we need to understand some of those trajectories, that some kids are on a worse trajectory than others, not to mention when they're dually diagnosed. I don't have time to talk today about dually diagnosed, but take it very seriously. It's a rule rather than the exception that your patients have at least one co-occurring psychiatric disorders. 70 to 80% of all clinical samples for adolescents with substance use disorder have at least one psychiatric co-occurring disorder. About 50% have 3. You need to address them both, and sometimes what comes, it's not just a simplistic disease model versus self-medication. There is a common liability index that's run in families where you have alcoholism and conduct disorder, alcoholism and depression. So you need to address them simultaneously. I don't have time to talk about it right now. Take it into consideration. When you do the assessment, you need to assess co-occurring mental health. If not, like many of your patients, look in the mirror. You're in denial and avoidance, and you don't want to be there as professionals. So what are the common concerns usually that we have with our kids? Why is it so difficult to work with them? So let's face it, this is a difficult population. Most youth are dually diagnosed. I mentioned trajectory issues. There's a chronic recurrent course of many of them. Fewer social resources, especially if they come from the juvenile justice system or from the Department of Children and Families, or whatever you call it here in Sydney. Family disruption, it's always there. Reduced compliance, we know that engagement is a major issue with our kids. Risk appraisal deficits. When we talk about sensation seeking or impulsivity, all this umbrella of what I call disinhibition. They also have delayed discounting. If some of you have heard the term, delayed discounting is, in roughly speaking, means they don't assess the situation very well, and they take unnecessary risks because they think that certain things not happen to them. For example, it's very common in research on pathological gamblers. You know, the people say, gee, you know, I put number 7 on the roulette. Number 8 came. I was so close. No, you were not close. It's an illusion. But this is how they look at this aspect. It's very interesting. And poor coping skills. They don't have good coping skills. Self-efficacy is not there, or it's not well. So we have so much to do in order to work on this cognitive restructuring, because to simplify something that is not simple, in order for somebody to change, they need a reason. So there need to be a very clear reward. And again, I'm simplifying it, okay? Also, it needs to be feasible. They need to believe that they can do it. And many of our kids are, quote unquote, see themselves as losers. They don't do well in school, they don't do well in peer social, they have legal problems, they have psychiatric problems. They have this feeling they're about to fail anyway. So I'd rather have an attitude than try to do something that I'm not going to do very well. And to recite one of my favorite statements, of course by somebody else, attributed to George Bernard Shaw. For every complex problem, there is a simple solution, but it's always wrong. So we, as human beings, look for silver bullets. We want quick fix. There's no quick fix. Becoming addicted is not an event. It's a process. So in order to make things better, we need to reverse the process, and it's not an event. Unfortunately, this is an expectation from us by the public, which is very problematic. And many of our patients are not very cute. They're not very likable. They make it very clear they don't want to be liked. So it's not like the old lady who has diabetes or the person who has high blood pressure. When somebody is a big, strong, adolescent with an attitude who's using drugs, they don't make themselves very likable, and the community are not invested in them. So that's another struggle that we have, how to deal with public perception, because public perception also affects resources. And I showed a slide yesterday that in the United States, 25% of the population are under the age of 25. However, in terms of resources, only 1/9 of the resources is invested in this population. So we have a discrepancy, and that's a major problem. I wonder what's happening here. I hope it's better, but we need to be aware of that, because I see all of you, all of us, as ambassadors for young people. Because if we're not going to do it, who else is going to speak for them? Now, what do you need to have in a program? This is actually based on a pediatric publication about a decade ago, and they reviewed programs and came with a list what needs to be in a successful program. And on average, only 4 to 5 of these 9 elements exist in each and every program. So think about it, because all of you are invested in adolescents. Which one of these 9 items do you have in your program? And what else would you like or do you need to add to your program in order to make it a little bit more successful? Not to mention the continuity of care, which is a major, major issue, because everybody talks about it, people don't do a lot about it. And why is it so? To make things simple, again, we have 3 kinds of outcomes in treatment. First outcome is the one we all love, which is abstinence. Great. 30-40% of kids will get abstinence, not more than that, in an ordinary treatment. Then we have the kids who don't get better, they even get worse. Let's call them the poor responders. I don't like the term non-responders because it sounds very desperate and hopeless, but let's call them poor responders. Hopefully we can do better. I'm not running a workshop here, but I like to do workshops and talk about how you address those patients, how do you work with them. We also developed a manual for phone intervention. How do you improve motivation? Because if there's no motivation, why waste time on coping skills and treatment? If people are not, You lead a horse to the water, you can make the horse drink. Anything else doesn't matter. First of all, the horse needs to drink. First of all, you need to stick your foot in the door like a salesperson and try to move them from pre-contemplation to contemplation. You need to have a dialogue. You need to address the ambivalence. If we don't get there, doesn't matter what we do. It's ridiculous. It's like yelling at somebody across a closed door. They don't listen to you. So that's a very important issue. And the third kind of group is those that have made some progress they've improved to some degree. So the question is how to address each one of these groups and how to make changes in our intervention in order to address the problems that have not improved well enough. That's why it's very important to set goals. Goal setting is extremely important. Research on goal setting is very poor, by the way. So it's important to understand in terms of continuity of care, and which is the essence of my presentation, how you need to look at treatment as one continuous, not just as prevention period, treatment period, continued care period, but how to address it together. And also the message to our clients or patients or kids is, we are not done with you yet, whether you're doing better or not. We'll keep on working with you, or we will continue to connect with somebody else. So there are two elements or two terms that I'd like to use. One is case monitoring. The other one is case management. Case monitoring is you follow what's happening with the kid, but you don't necessarily get too involved in it. But periodically you assess or reassess the situation, the condition. Case management is a little bit more challenging, but more powerful, because as we know, the kids we work with don't have a unidimensional problem. They don't have only substance use disorder. They have psychiatric issues, they have family issues, and or legal issues, and or academic issues, and or peer social issues, and or legal issues. We need to address those issues. You can't just address one, and that's case management. It's a lot of work, but if we do it, we have a better chance to work with them. So the statement, I'm kind of joking that there are certain things that I say in my presentation that I start to believe that I invented them, but I'm most probably citing somebody else. But these are like mantras. So substance use disorder is a multidimensional problem that needs to be managed by a multidisciplinary team. So I can be the champion of the world in terms of substance use disorders and maybe mental health issues. I'm not an expert on school. My private kids tell me I know nothing about school. I'm not an expert on the legal system. So you need to have people in your team that are complementary and will improve the total investment that you have in the case management. And for example, we have at least half of the referrals to our program come from the juvenile justice system. So we develop very nice relationship with probation officers, and even the judges send kids to us instead of sending them to jail, which I think is progress. So they understand that we need to address the needs of these kids. Punishment is not necessarily an answer, but it takes a team. So it's very important to have a competent team of people who complement each other. We need to help these kids graduate from school. Do you know that people who don't graduate from high school, at least the United States, they lose 15 years in terms of life expectancy. They become parents earlier, which means that they doom their kids to a third generation of poverty, substance abuse, and other problems. So we need to invest in those kids as early as possible, because if we don't, we are adding to the sins of the fathers, the problems of the kids. In terms of treatment, sometimes people argue about toxicology. Is it respectful or disrespectful? Guys, we need to be sometimes pragmatic. Most of the kids, by the way, although lay people will tell you otherwise, will tell you that they've been using. But you need to have some objective findings, because if I treat a kid for cannabis use disorder and suddenly I get cocaine or opioids in the urine, I want to talk with him about what's going on and why is it happening. Can't just rely on formal or informal information. And again, it's part of the concept of treatment. I mean, you say, listen, there are certain things I'd like you to do. And most kids don't have a problem with this. So that's a very important issue to do. Active ingredients, we're going to see a lot of acronyms, but you don't necessarily need to be licensed and certified to make a change in a kid's life. It can be even my research assistant, or a grandma, or a preacher, or a midnight basketball coach, that if those elements are being put together, as developed by Miller and Sanchez. Miller is, the iconic researcher from University of New Mexico in Albuquerque that developed the motivational interviewing protocols. So if a person provides a kid, and allow me to use the term kid, I hope nobody thinks that this is like disrespectful. There are kids. It doesn't matter how old they are our kids. So there's definitely some emotional investment for me in using the term kid. So if you have feedback on personal risk and impairment, not necessarily preaching, but addressing this issue, talk about personal responsibility, clear advice to change, a menu of alternative, empathy, and facilitating self-efficacy, you are on the right way. And I don't want to get into a debate right now about political correctness of each one of these terms, because, for example, there are some avenues in the United States, maybe here as well, that say, no personal responsibility. They were born in bad circumstances, and they should not bear responsibility for what they do. We can debate this issue. What does it mean? Not what does it mean just socially or politically. What does it mean for a young person who's growing up and need to decide what is right and what is wrong and how to improve the quality of their life? So here's a great question. When does treatment start? How does it work? Very simple. So for the pediatrician among us, we have this BIRT, screening, brief intervention, referral to treatment. Unfortunately, especially in the United States, I discussed it with our pediatricians here. Usually, a child is being seen every year by his pediatrician, and the average session is 9 minutes. You cannot do much in 9 minutes. Definitely can do brief intervention. Hopefully, you can provide some referral. But I know that here people have a little bit more time. For my colleagues in West Mead, so that's great. Although again, I understand that here you have like first line and second line of pediatricians, but kids deserve, if you, after the screening, you realize they have a substance use related problem, you need to spend more time with them in terms of the assessment. So that's a very important issue. Let's move on. Mechanism of behavior change, the last item. There are several of them: motivation, readiness to change, self-efficacy. To remind you also, self-efficacy is a subjective feeling or belief that you are able to address high-risk situations. So if you have kids who say, I want to go to parties, you better prepare them for what's happening in parties and how to say no to drugs, because in the beginning maybe you say, well, let's do denial and avoidance, avoid parties. But if they have nothing else in their life and they want to connect with their other friends who are users, the question is, how do you prepare them for high-risk behaviors? So we've done some study on assessment reactivity, meaning what happens when somebody just being assessed for their problems. Because, imagine you drive along the freeway and you see a road sign that asks, do you have an alcohol problem? If you ask yourself, do I have an alcohol problem? Treatment has just started. There is a certain level of awareness. So likewise, when we administer rating scales and all kind of asking questions about your drug use and alcohol use, it is powerful. And what we have found is that because we used to do a lot of group therapy and we used closed groups, so it took 2, 3 to 4 weeks to put a group together, the question, what's happening in between? Are we losing people? We are not losing people. The dilemma whether to do revolving admissions to group versus setup groups. So we decided to assess just before the first session, assess again in terms of doing objective urinalysis, and lo and behold, we found out that many kids already have been clean, which made me really panicky, and I was looking for the closest paperback to put on my head, because I said, my career is over. If everybody improved before I treat them, I better do something else in my life. But hallelujah, we find out that actually kids continue to improve during treatment. But those who improve quicker basically have a better prognosis. So that's kind of interesting, that response to treatment is the best prognosis in terms of what's going to happen later. So don't underestimate any kind of contact with kids, any kind of talking with them about substance use disorders and so forth. There is, I don't know, it gets there by osmosis to some of the kids, and that's really important. Why does it happen? There's a variety of explanation. Maybe they gave the word to someone, but maybe it has the frames that we saw before, you know, this acronym. But something is going on and something positive is happening. So just referral to treatment is fantastic. Those of you who are old enough to remember the 1977, 1978 advice study done, you know, in England, that the study was very simple. People who smoked got to the doctor. Half of them, the doctor said to them, "You're a smoker. That's no good. You gotta quit." And the other half, they didn't give them any advice. There was a change in tobacco use between these two groups, which was quite significant. It's kind of interesting because you know that nicotine is a highly addictive substance. So it's kind of interesting, what are the mechanisms of behavior change and how we can use them, manipulate them, start them. It's very important to understand it, particularly with adolescents. What makes adolescents decide, I'm going to change? Okay. I want to tell you something that, I don't know, you haven't heard it on the news yet in Australia. It comes all the way from the United States. The chicken and the egg have settled their controversy. They are working together. They're not arguing anymore who came first. But, and this is actually a book that somebody wrote, and I kind of bought it and made a slide out of it. So the bottom line is there's a lot of chicken and egg questions in medicine and definitely substance use disorder. What came first? What started first? And the question is, how important is it to understand it? And what are we going to do about it? Because we don't want to be in the situation of don't ask, don't tell. If you ask a question, you may have to deal with it. We used to say that never ask a question that you may not like the answer you're going to receive. But if you do, be prepared for that. So in terms of heterogeneity, as I mentioned to you, what we have realized is when in treatment, we are neglecting a lot of aspects that are very important to understand. The trajectories that people have different trajectories in terms of development of substance use disorders, and we need to take it into consideration in terms of how do we design a treatment plan. What about severity at baseline? There's definitely a difference in severity, and you need to take it into consideration, whether it's severity of depression or severity of substance use disorder. How do people respond to treatment? As I mentioned to you, abstinence, reduction, or increase of use. What about the consequences? So when you develop a treatment plan, it's extremely important to take all these issues into consideration before you start treatment. It's very comprehensive, and you look at different aspects of your patient. As you can see, some processes are very common and general, and some processes might be more specific. So the question is, how do we tailor this elusive patient treatment matching? And this is really the challenge we are all facing, and we are not there yet, like are we there yet? But at least we should ask the right questions and try to find the answer by research. And that's why it's very important to collect data in your clinic, and every now and then look at the data and ask a question and find out if a certain phenomenon or trend is indeed worth studying. If you want to confuse you, there's some people who've been doing this kind of research, for example, on cognitive behavioral therapy. How does it work and all those elements? There's a very good paper by Black and Chang in a special issue of Substance Abuse Journal that I edited. I kind of commissioned them, asked them to write this specific paper to explain how does treatment work. By the way, if people are interested, either as a group or individually, feel free to send me emails. I can always send material. I think it's my obligation to send it to colleagues in the field because it's important that we will all be on the same page from the same book in order to keep on moving forward instead of reinventing the wheel over and over again. Thank you. Likewise, 12 steps, which is extremely important, and John Kelly, my colleague, has been doing research on 12 steps with youth for many years. I won't get into mediators and moderators, it's too much research oriented, but definitely we need to take it into consideration. And also what happened from a developmental perspective. Where is the science going right now in terms of neuroimaging to try to understand what's happening in the brain and how does it affect certain intervention. The future is now. There's some people who've made amazing progress in terms of understanding, like Sarah Feldstein and a couple of other people, where the changes happen in the brain, even in psychotherapy, similarly to medications. These are the three groups that I was talking about. And relapse is common, but as I mentioned to you, we cannot talk about relapse prevention if the kids are not clean. So we need to address relapse prevention with those who have made progress, and we would like to maintain the progress, the achievement. Those who have not achieved abstinence, we cannot talk about relapse prevention. So be aware when we say relapse prevention, it's applicable only to about 1/3 or 40% of the kids we work with. As you can see, this is 30 months later after the CYT study I told you about at the beginning. The numbers are not pretty, meaning we are working in a very treacherous, difficult field, but we need to be aware of that. It's like when you are on your way to hike, I don't know, a certain pathway or a certain track, you need to know what to expect. It's not hanky-dory, it's not easy. You need to understand what's going on, how difficult it is, and we try to understand how to make improvement with these subgroups. That's why I differentiate between continuation and relapse prevention, as I mentioned to you before. Aftercare, how important it is, it's super important because at the end of treatment is not the end of the process, because as you know, within 3 months, those who even achieve abstinence, up to 60% relapse, within 3 months, up to 80% relapse after a year. So something needs to happen. Now, it does not mean treatment does not work. It means treatment is not over. So you need to coin it differently, call it the continuity of care or the aftercare or the adaptive treatment. And as I mentioned, what we are doing, the kind of research we do right now with substance abuse users only or with dually diagnosed adolescents is try to develop other branches to this decision tree and algorithm to make it work. Again, I don't have time to talk about it right now, but exactly what we do with the co-occurring depression, but it's definitely an interesting process. I would just tell you one thing though, that even if you have kids with co-occurring disorder such as depression, and if you just address the substance use disorder, 30 to 40% of them will benefit, and there are going to be a reduction in their depression scores. And why is it so? Because of a mechanism behavioral change affect different aspects of your behavior and your pathology. That's amazing. It's the same even if people have anxiety disorders, even if people have ADHD, believe it or not, you provide them with CBT, even if they don't get medication, there is improvement in some of those kids. I'm not saying that you shouldn't give medication for kids with ADHD. Absolutely you should. But this is the power of cognitive behavioral therapy. It does something. Because remember, I'll get into psychiatry in one sentence. Even patients who suffer from very severe psychotic disorders such as schizophrenia, bipolar disorder, and another disorder like ADHD, in order to improve the quality of their life, it's not done by medication. It's done by providing them with some improved coping skills, managing their everyday issues. And this is complementary to the medications per se. So all these behavioral and cognitive interventions are very powerful. Let me stop here because I don't have time to talk about abstinence versus harm reduction, which is something we're writing a lot about right now. You know, I'll be happy to answer questions, and maybe people can approach me during the break or during lunch, and you know, we can talk about it. So should we take questions now? Okay. Let me just see if there's any.
So thank you very much, Yifrah. Do people have some questions? Would anyone like to ask a question?
Actually, I wanted to show you, at least in America, I can make such jokes. This is a slide we developed before the elections. Talk about choices, harm reduction, American style. Yeah. Well, at least in the United States, you don't go to jail for that, because I came to Turkey and I showed you, they laughed, but I didn't say anything else about what's happening in Turkey because it would be the end of me. But there's no easy choices. That's what I want to tell you. So anyway. No questions? I have so many questions to myself. You guys have no questions? Everything is hunky-dory?
Yeah, g'day. Welcome. Thanks for a great talk. It's not really a question, just a comment. Very little of what you said seems to me inapplicable to where I work, which is with adult substance misusers. I mean, we don't as yet have the under-18s in our catchment. I'm hoping that may change. But all the points you made about multi-adaptive, multi-dimensional apply just as much to the older population. This is not to in any way diss what you've been saying, just that it's a continuum.
Okay, so I guess it's a comment, it's not a question. Okay, that's fine. Yes, over there.
Hello, Pip Bowden, Psychology and Counselling Manager from Western Sydney. We live in an era where we are constantly seeking the new and wanting better and better treatments. And we can be a little bit faddish in our treatment approaches, and we can be a little bit focused on the quick fix and medication. I'm really heartened by your focus on cognitive behaviour therapy. How is it that you maintain interest and excitement in cognitive behaviour therapy as an ongoing treatment today?
So the question was, how do we maintain excitement? Yes. I don't know if I want to stimulate my patients any further, if you know what I mean. You know, our approach, and again, we developed all these manuals of CBT, and I think that there are two issues. Are you a family therapist by any chance? Okay, good. It's okay, although I don't like these silos. I usually say to our therapists, I say, look, I need to take it for granted that you're competent because you have a licensure and you have certification. What I'm providing you in terms of manuals is the adherence. I would like you to follow the protocols in a way that is very useful, and we also do very strict supervision, audio and video, and it's kind of interesting the way we do it. And again, I'll be happy to share our protocols. The therapist and the supervisor are using a very similar questionnaire. The therapist is answering the following question: have you done the following? And the therapist answers the question, the supervisor, has he or she done the following? And we have a discussion. So first of all, there's mirroring here. Have you done the following? Were you empathic? Have you emphasized discrepancy? Have you complimented any comments that show motivation to change? Have you provided the following coping skills in the session, for example, drug refusal skills, or management of negative affects, or peer networking? Because, you know, one of the problems with the kids we work with, we hope they have two networks of users and non-users. So they'll hopefully spend more time with the non-users. If the only network they have is of users, it's kind of problematic, because then you deprive them of their friends because they don't know anybody who is not using. So all these issues of getting into the CBT element, and therapists actually are very interested in doing this. And I'm telling them very clearly, I'm not taking away from you your creativity or your experience. It's not very dogmatic and technical and robotic. It's a tool to make treatment useful and also understood, or if you will, digested easier by the client, because CBT is very specific. Now, I'm not dissing family intervention or other things. The issue is that not everybody has a family. Many of our kids don't have family. Some of your kids, I would recommend parentectomy because they come from families that are very toxic. I have parents who send the kids to us because they raided my stash. Zero insight. And when you provide them with the opportunity for treatment, say, no, I'm okay. Take care of my kid. So that's definitely an issue. Also, cognitive behavioral therapy, in terms of resources, we all have limited resources, cost about a third of family therapy. So if you can conduct family therapy or do ACRA, community response approach, which is less expensive than MDFT, that's great. But the CBT elements in all of this intervention, I don't know how big AA, NAA are in Australia, but there's so many CBT elements in AA. You need to pick up a sponsor. Sponsor is a role model. Sponsors give you feedback for your behavior. Sponsors give you all kind of points how to deal with crisis intervention in the middle of the night when you wake up in craving or you're depressed. So this CBT, the behavioral aspect and the cognitive aspect, run along all these interventions. And you don't need to have people who are PhDs or even master level to conduct, to provide MET CBT, so it can be less expensive. So I see a lot of advantages to that, given what are the resources that you have available. I hope that my long answer kind of partially answered your question. Yeah, okay, thank you. Yes, ma'am.
Thank you, it's been very entertaining. You said that kids are not little adults. There's all the developmental issues. How important is it for us to have a sound grasp of those developmental issues if we work effectively with the kids?
Well, I think that Therapeutic Alliance knows no age and no boundaries. I think that it's more difficult perhaps to develop it with adolescents because we have a problem. We are grown-ups. So there's already a discrepancy here or less of symmetry in terms of the power. You know, the adolescents, we are adults, and the question is how they're going to be working with us, especially when many of those kids come to treatment not for the first time. So they're already being, I don't want to call it traumatized, had some negative experiences. That's why motivational interviewing is a very good way to start it, to prime the patient, to serve as an appetizer because it's patient's focused. I hope that, you know, people will do motivational interviewing, and this is a way to put the center, it's a patient-centered intervention where we say to the kid, okay, where are you now? Where do you want to be? And I remember first time working in the prison system and ask a kid, where are you now, where you're going to be? He said, I want to be like you. I want to work with kids. And I almost laughed, and then I said, what an idiot I am. I need to understand this entrepreneurial aspect of them and the altruistic aspect. He wants to help kids like him. This is how he says it. So we can provide them with the tools to do it. So it's very humbling experience working with our kids because we learn a lot from them about what's happening to them, and we need to adjust it. But we need to set boundaries, and we need to explain to them, listen, you're here because you have certain problems and issues. And let's see how we can move forward. Now, very young kids, especially if you work with kids under 16, like some of my colleagues work, have very poor insight because developmentally it's a very early stage. So if a kid tells me, ask him, what is your problem? I mean, what would you like to address? I said, I have no problem. The judge has a problem. He sent me here. This is total insight, lack of insight. But you can't tell him you have no insight because he doesn't understand what it means. So we need to make it simpler and said, well, let's use the domains of the Teen Addiction Severity Index that we developed. You have no problems. Okay, actually, if they don't like the word problems, they like to use the term issues. So I've learned to I said, so let's break it down. I think it's school. School sucks. It's terrible. Okay, I think at home, my mom, she's on my case. Do you have a probation officer? Oh, he's a terrible man. So now it's more concrete. Said, how about you and I pick up one of those issues and work on improving them? So the kid says, I might get something from this guy. and this is how the relationship starts. So you break it down into smaller pieces that are age appropriate, and that's a developmental aspect. Working with adults is easier because they have more insight and they understand the losses. My wife going to kick me out of the house if I keep on using, going to lose my job, I'll go to jail. I cannot handle it anymore. So as adolescents, no problem. I don't care if I don't go to school, and all kind of issues. You know, it's almost like when we use the term countertransference, if you remember the old psychodynamic term. What I have towards many kids that I work, I want to hug them and smack them at the same time. And you know what I mean? It's like, don't you see what you're doing to your life? But they're not here to get speeches and pressure. It doesn't work. The question is how to try to make it work somehow together. And this is where you need to understand development. Because if we ignore the developmental stage and we treat them like adults, it's not going to work. If we treat them like little kids, they're going to resent it anyway. So the question is how to build this therapeutic alliance and the process. And that's why we do a lot of what we call in research, we do functional analysis every now and then. So I sit with little Joey or little Maria and said, okay, let's see where we are. What have we done until now? Where are we heading? And it's a discussion. And it's helpful. It's something you can do with yourself in every pathway of your life. Where have I been? Where am I going to? Because I have certain issues. I have some debts. I have some, mortgage issues. I have some problem with my kids. I have some whatever. Where am I in resolving this issue? Where am I heading? And this is very similar in terms of functional analysis, working with adolescents. It's not easy, but it's a respectful process that you do together with them, so you don't just tell them what to do, you work with them. And at the end of the day, if they keep on coming to see you, something good is happening. Because you know how many times they just don't. Yeah.
I'm sure there's more questions, but this afternoon, of course, we have half an hour panel discussion, and Yifrah's going to take part of that with us. So could you join with me in thanking Professor Kaminer?